Welcome to the Training Institute for Dissemination and Implementation Research in Health Pre-Institute webinar. This webinar is being recorded. If you have any objections, please disconnect at this time. Just a few session logistics before we get started. Please take a moment to make sure your phone is muted. At any time during the presentation, you can submit a question using the Q&A tab on the right of your screen. Type in the provided field and submit. All questions will be answered during the Q&A portion of the session. We will now hear a welcome message from Dr. Vishwanath. If you are participating via telephone, please turn on your computer speakers to hear his message.
My name is Vishwanath. I'm a professor of health communications at the Harvard School of Public Health and the Dana-Farber Cancer Institute. I'm also one of the hosts of the workshop of the 2014 TIDIRH workshop. On behalf of the Harvard University and the workshop, I would like to welcome you to the webinar on dissemination and implementation science. Today, you will get a brief overview, in fact, just a brief taste of what you will hear and learn about dissemination and implementation science over the one-week course of the workshop. You are in very good hands. This overview will provide you with a brief introduction to dissemination and implementation science and what you can expect when you are here in Boston next month. I hope you enjoy the webinar and find it useful. I look forward to seeing you all in Boston next month and welcome you in person. Thank you.
Turn the call over to Dr. Cynthia Vincent.
Good afternoon, and welcome to this webinar to introduce you to the Training Institute for Dissemination and Implementation Research in Health. I wanted to let you know that the session is going to be a little bit different than how it was originally presented. We're first going to have a presentation from Dr. Ross Brownson on dissemination science and designing for dissemination, followed by a presentation by Dr. Amy Kilborn, focused on implementation science. And then Dr. David Chambers and I will be giving you an overview and some logistics for the Training Institute. So I'm going to have David talk to you a little bit about the overview of the Institute. Here we go.
So what we wanted to do in general is just give you a flavor for what the sort of overarching goal and some of the thinking that we have that has led us to develop TIDIRH in the way that the agenda will unfold. So you can see right here that the broad goal is how can we collectively build the capacity for D&I research. Of course, you'll see that this is primarily an effort to think about how can we increase our collective skills around a variety of topics in implementation science, to think about how we can prepare cohorts of investigators around their individual projects and make sure that they're as scientifically rigorous and as impactful as possible, but also thinking about how you all as trainees are really a window into the broader network that we're trying to expand. And so you'll see that we have each year of TIDIRH had a different host institution. And that's really been this effort to try and continue across the country to build the broader capacity. We started in North Carolina. We then went to California, to San Jose, with UCSF as our local host. Last year, we were at Washington University in St. Louis. And then this year, of course, we've got Harvard as our local host, both by the trainees really serving as ambassadors beyond this program and pulling in local expertise at the different institutions. We've really seen that TIDIRH is this broader way to try and build the capacity for training. We also see that this is a great opportunity to try and share the information that we're going to be discussing over the week. Think about ways in which you might be able to bring it back to your host institutions, thinking about ways that conferences can be opportunities for you to continue to network, as well as thinking about the funding opportunity announcements that we at NIH and other agencies and entities, foundations, have had as further opportunities to grow the field. And so it really is this broader concept of how we collectively can advance capacity that we're dealing with. So you'll see just a few of the general features around TIDIRH. It is very much crafted as a residential training. We have this idea that us all being sequestered in the same place gives us a wonderful time for both diving in deep to the content, promoting interaction, and thinking about all sorts of opportunities to network. You'll see the model of a train-the-trainer approach, where we do hope that you'll take the materials that we're making freely available, the slides as well as notes on each slide, to be able to bring back to other networks, to other constituencies that you're connected to again try to impart broader information about dissemination and implementation. We've been trying to be as flexible as possible. We have daily evaluations that we hope that you'll provide feedback on, so that we can continue to refine the program to meet the needs of you, because if you don't get your questions answered, then we're not doing our job well. There is, of course, substantive and methodological content that makes up the agenda, and there's opportunities for you all and us to connect in small groups and really think about how can we advance your your own projects and learn from each other as you're doing so. So just a couple of principles of TIDIRH. We really do try and stress that we want everyone to participate as much as possible in the sessions. So we do try to limit email and multitasking making its way to the forefront during the week. We really do see the opportunity to develop your own research within small groups, to connect with people who have really good insights and expertise to add. We really do want you to be connecting not only with the faculty and their expertise, but with the funding organizations that could potentially support your work in the future, and offer an opportunity for appointments at the end of each day to connect one-on-one with folks. We hope that you see each other as colleagues around collaborations in the future, that you may see papers, you may see projects that can come out of the networking that you're able to do. And again, we really do want your feedback each and every day and at the end of the week, because we see this as a learning collaborative, as a way to promote sort of ongoing capacity building beyond just this 1 week.
Excellent. So I am actually going to turn this over to Ross now, since I see him on the line, and I'm hoping when I pass the ball to him that the audio will be able to kick on. So Ross, if you go off mute, we'll be able to hear you. Sarah, maybe you can take him off mute.
Okay, can you hear me?
Yes.
Hello? Hello?
We can hear you, Ross.
Oh, you can hear me, good. All right, I was a little nervous. So you can still hear me, right?
We sure can.
Yeah.
Okay, then I will go ahead and I will try to do it in a little quicker time, since we lost a little time with the technical difficulties. Hi everyone, I'm Ross Brownson from Washington University in St. Louis, and I'm here to give you a quick overview on dissemination science and designing for dissemination, along with Amy Kilborn, who will be on hopefully in a minute, to sort of whet your appetite for some of the things that we'll cover when we're here. So I think we're going to have a good time together. I'm really glad that you've signed up for TIDIRH and have made it through the rather rigorous review process that we have. And so you always ask, well, why are we here, and when do you know when translational science and dissemination and implementation research has arrived? And I always have two indicators of that. One is when it makes it into the popular press and people are talking about it. This is an article from several years back, about 5 or 6 years ago in Newsweek, that talks about the valley of death when we have all these biomedical discoveries that we're not applying. And so it's made it into popular press. The theme here really, this is one of the main medical health reporters of Newsweek, Sharon Bagley, that we're not applying what we know, and that sometimes scientists may not be the best translators, that we meant be the best ones in the middle of the pipeline. Some are good at discovery, some are good at communication, but we need to have many disciplines at the table to be able to do this well. And then, of course, you have to have a cartoon. So this is one that says the latest research shows us we really ought to be doing something, all this research. And that is certainly, I think, underlying a lot of the reasons why all of us do this, that we're not doing it just for the sake of discovery. We're doing this work to make people's lives better, to make populations healthier, to add in medical discoveries and not just discover knowledge, but apply knowledge we've learned. And so that will be a big theme for the week when you come to Boston. I'm going to briefly cover a few definitions, a few of the differences between dissemination research and research dissemination, and that should segue into what Amy will talk about related to implementation research. I'll talk briefly about some of the theories and where to go to learn more about theory. You'll also be learning a lot more during the week about theory and program planning frameworks, and then we'll talk a little bit about designing for dissemination. So this is my own sort of arbitrary set of distinctions between dissemination and implementation. Dissemination is out in the broader world, so you probably could call it more messy, although implementation can certainly be messier as well. Because implementation usually works within a particular setting, like a school or a clinic, it may have a little more control. A dissemination tends to happen at the larger level, at policy levels, media levels, over a whole community or even a whole state. And as you see here around the target, this gets to smaller groups and more individuals when we talk about implementation. And really these all focus all across levels of prevention, from primary prevention of risk factor change to early detection, like early detection of colon cancer or breast cancer, to tertiary prevention, treatment, rehabilitation, reducing the health effects after having some chronic condition or another health issue. Very briefly, some of the definitions that are important in dissemination implementation research is dissemination. Some of the operative phrases here are around spreading and evidence-based intervention, and then this idea of channel. So a channel might be a media channel. Implementation, the key, again, we talk about evidence-based interventions, but also we think here especially about a specific setting, and then the object of D&I and D&I research is always something around evidence-based intervention. There'll be discussions during the week about what an evidence-based intervention and sort of what the evidence bar is and should be when you're thinking about a project, when you're writing a grant, when you're trying to implement something out in the real world. What do we know about dissemination? Well, we know several things, and this really comes from a diverse literature, not just health literature, but really going back to the early work from Ev Rogers in Diffusion of Innovations. It's not spontaneous. It doesn't naturally happen. It will happen at a low percentage naturally, but to happen on a larger scale, we need more active approaches. That implies that passive approaches don't always work all that well. Single source prevention messages are often not as effective as more ecologically focused, comprehensive, and multi-level approaches. So if you think from the individual to the organization to the policy to the system and the whole community, that is often the more effective approach. Participatory involvement with stakeholders in the research and the evaluation process is likely to make our efforts more effective. Theory and frameworks matter, and they're beneficial, and that will be a big theme for what we'll briefly touch on today, and then much more during the week. And then the dissemination needs to be tailored to different audiences. If you do policy dissemination research, what a policymaker wants would be very different than if you're trying to disseminate to one of your research colleagues. So that's important to keep in mind. It's also sometimes useful to think about the distinction between research dissemination, that is, the dissemination of our knowledge, or dissemination research, that is, doing research on how knowledge is disseminated and translated. Of course, there's a lot of overlap between those. In the past, I think a lot of the work in putting our research out there and disseminating our research has been more passive. We sort of think that we'll publish our articles, we'll give a presentation, it will magically pick up. And federal agencies tend to fund both. They tend to fund both research dissemination and dissemination research. And I would say the CDC especially funds both ends of that continuum. And there's really a lot of overlap between that and what I'll talk about later today in terms of designing for dissemination. It's kind of setting us up for that idea of how we better disseminate and reach audiences. Now is the time for a little audience participation. So I'm going to hand it back over to Sarah, and what I'm going to do, we're going to have 2 questions, and we're going to ask to do a little polling. So if you'll go to your computer, and each of you should be able to pick the answer to this question. Of the methods down below here, where you use these methods to disseminate your research finding, which one do you think generally has the most impact on your career trajectory? So if you'll go ahead and click on that. Okay, let's see. So we have of those, so we have no answer in the mix, but by far the winner, as you would guess, are academic journals. Next would be face-to-face meetings, and then we look like we have a tie between academic conferences and media interviews, and those get down to just a couple respondents each one. And then policy briefs, we have, thank goodness, we have one policy wonk out there who answered that one. Okay, so that one clearly indicates that the winner there is the academic research journal. Okay, now let's see about which of these, when you disseminate your research findings, here's another poll for you, which one do you think generally has the most impact on public health or medical practice or policy? And if you work in mental health, use that. If you work in social work, use that as the endpoint. So in the practice of whatever discipline you're in, which of these has the most impact? If you'll go ahead and click on that, we'll do a similar poll here. How are we looking for polling, Sarah?
We are looking good. I just need a few more moments, and then I'm obligated to wait about 15 seconds to publish the results, but I will publish them in just a moment.
Okay, good. And we'll hang on for just a minute. And actually, will it let me go on to the next slide and then look over the results in a minute?
It should.
Okay. Well, then let me go on, and I'll show you some of our data where we've surveyed practitioners in public health. These are in local health departments, and asked them how they best learn about research findings. And then we've surveyed many hundreds of public health researchers and asked how they most effectively reach practitioners. So that one on the right is a little different than the answer you just looked at, which is more for your career. But what you see here is a mismatch where we're down below. See if I can highlight. You see journal articles. That's the 4th on the list. It's a fairly distant 4th for practitioners. And then we see up here journal articles, which by far wins for for researchers in terms of how they think they can most effectively reach. And so now if I look at the findings from the little poll we just did, which is the answer to this question, the winner here is face-to-face meetings, followed by a tie between policy briefs and media interviews, and only one person out of 39 said academic journals. So the point here is, and this can inform your dissemination research and also can get you thinking about how your research can have a better impact once your research is done, that we have quite a mismatch here between the method that's going to further our careers. It's sort of a driver behind the incentive of those of us in academic and research settings, and then a mixture of things between policy briefs, face-to-face meetings, seminar workshops that also help to drive reaching practitioners. So just a backdrop for you to think about, which relates pretty closely to what we found in our national survey data with both practitioners and researchers. So let me shift gears a little and quickly move on just a little bit about theory, because you're going to hear a lot more about theory at the meeting. There'll be a reading in your materials from Rachel Tabak et al., which is a group here with us, and David Chambers is also a collaborator on this work, where we reviewed all the D&I models that are out there. We found 109 models, we excluded some, and we ended up with 61 models in our review. And of those, only 11 were dissemination-only models, and we characterized these across 3 domains we called construct flexibility, which means there's a more broad model, like I want to study cardiovascular disease dissemination in all of Canada, versus something operational, which is much more down in the nitty-gritty with measures and the individual constructs that you might use in a research study. We looked at the SES is the social-ecologic framework, which is ecologic levels from the individual all the way up to the system. Does the model focus on one level, multiple levels? Of course, most of these impact on multiple levels by the nature of D&I research. And is it more of a D framework, more of a dissemination framework, or more of an I framework, an implementation framework? Or equal, or kind of doing both? And so I want you to really take a look at that. We will be talking about that during the week. We'll provide you with the article, and we'll also provide you with a set of PowerPoint slides that will show you all 61 models, and we'll try to provide you with guidance on how to choose the right model for your research. Along with that, we'll be talking about some advice. First of all, you have a theory or model. We want you to have one. Can you link it all the way through your proposal? You know, we want you to come out of this week with a refined concept of the research that you want to implement and get funded. Does it go all the way from the aims all the way up to your analysis? When you're finished with your work, can you advance the field by adding new measures for a theory or framework, or learning some new nuance about it? And then, is there a theory from outside of health? For example, here, the theory I mentioned here in streams of policy, that's from the policy world. That's Kingman's policy theory that's used widely in political science. The DOI is diffusion of innovation. Okay. And then lastly, and I'll hand it over to Amy, as a few words about designing for dissemination. This is from that same survey of 266 researchers in the U.S. We asked them to sort of self-rate how well they think they disseminate their research findings to non-researchers. This could be practitioners, policymakers, the general public. And you see, we're fairly self-critical. We only think 6% of us do a really great job of it. 22% think they're good, and 33% adequate, 33% poor. So you put together sort of adequate and poor, and it's 2/3 of the whole group. So clearly, in terms of designing for dissemination, doing a better job of this, there's a lot of room for improvement. And we published this now in American Journal of Public Health last year. This is what we call designing for dissemination. It's kind of thinking early about future adopters of your research, their needs, their assets, the time frame they might need, and then thinking about the active process that would lead toward more widespread use of your research, more widespread dissemination of your research. A few other snippets of the data. We found that about 3/4 of the researchers in our survey spend less than 10% of their time on dissemination. About half had someone to really help them with dissemination. I don't think we can assume that researchers are really good at this. About 1/3 always involve stakeholders, so we can improve there, and only about 1/5 use a framework or theory. We included some prevention research centers, the CDC-funded centers. They do better. Researchers who have had practice experience do much better. In fact, that's been one of the strongest predictors. And then, sadly, not to the colleagues on the phone, but for some NIH researchers, they don't do as well. NIH researchers across the board did a little worse. We can do better. We can do systems changes, and I've got some examples up there about funding incentives, new tools, new portals to get research out there in a more efficient way. We can change the process. We can engage stakeholders better through participatory research. We can make better use of theories and frameworks, and we can deliver messages in a more creative way. Social media, new ways of thinking of getting the message out there. And then we can create new products, new user-friendly summaries. And we have a much longer list of these with some discussion in the paper that I cited earlier. So my last little bit, the 3 take-home points, there's a close nexus. In fact, it's hard to sort of differentiate a lot between dissemination research and research dissemination. There are many theories, well over 60, and probably now even more, since we did that review a couple of years ago. And these will improve not only your research project, but your ability to design for dissemination, the D4D. The messier the research topic, the broader the dissemination, probably the lesser amount of really strong dissemination research that we see. So that's it for me. I will, I think, now hand it over to Amy. Hopefully Amy's on the line.
Yes, hello. I hope everyone can hear me. Thanks, Ross. That was a really great presentation, and I think at this point I'm now going to be presenting a little bit more on implementation science and giving folks a general background of the field, and really from I think Ross did a wonderful job of really showcasing the big picture around dissemination and implementation from a public health standpoint. And what I'll do is talk about implementation science and especially how it's applied to when you're working in a healthcare system, or if you have the opportunity to do health services research. So I got into the field of implementation science in part because I often felt like the last scene from the Raiders of Lost Ark, where I would spend so much time and energy in developing a researched intervention through my research, only to really just have it shelved away in storage somewhere on the academic shelf. And I really wanted to see it being applied more. And also because it was really an opportunity to really be more active in a way that we could further disseminate some of the research into practice. And really the fundamental problem in healthcare systems today is that new research takes too long to get adopted, and research is not aligned to address critical health or healthcare problems. And I think what has really slowed down the implementation of research findings into practice, especially for healthcare systems, is that providers often lack the tools and technical assistance to implement effective treatments. And then really that there's a lot of opportunity to study the implementation of clinical interventions and practices, but large programs or healthcare systems are rapidly needing to roll out new interventions or things that haven't really been tested fully in terms of their ability to sustain those things over time, with really inadequate planning to maximize effectiveness. And so finally, it's also the main problem of healthcare research and why implementation research is important here is that there's so much variation in terms of contextual factors, and that when you take a clinical intervention, it's often not going to be adopted or adapted in the same way across different settings. There's also that the main issue in healthcare systems as well is that despite the fact that we have treatment guidelines and effective interventions, many of the quality of care for many conditions really remains suboptimal. And this slide here really showcases the percentage of folks receiving recommended care. This was published by individuals at the RAND Corporation, really showing the depth and quality of care, and especially for conditions that required more than one healthcare professional involved, particularly for alcohol dependence or diabetes or depression, where you have to bring in a specialist in addition to a primary care provider. So I'm the director of the VA Quality Enhancement Research Initiative program, which is one of the unique aspects of the VA in which the Query program is designed, and it has its core mission of better implementing research into practice to improve care for veterans. And this pipeline here has really been the traditional way of which, essentially implementation has been thought of, is that you start with a research trial, you find an effective intervention, you look at some of the, you identify that best practice, and then you essentially look at documenting how it varies over time in different places, and you basically end up conducting implementation studies towards the end that really are more focused on how do you actually get that clinical practice sustained and used by providers in everyday clinic or everyday and real world clinics as opposed to tightly controlled clinical settings. So it was, I think, a helpful way of thinking about moving from the research trials to more identifying more effective interventions, to moving those into the hands of providers and conducting studies to look at implementation. But in general, I think what we're realizing more and more in healthcare systems is that there's simply situations where you don't have enough evidence to implement something, even when the healthcare system really wants to implement a clinical practice right away. So, and that's really, I think, historically been a big issue. And so we have done a lot of thinking about the field of implementation science, and really what Ross was saying earlier about designing for dissemination implementation in the first place. Why do we think like that? In part because in the past, I think really the fields of dissemination and implementation may really follow from a more iterative research process and not as though it follows linearly from clinical trials research or traditional bench science. And this is really an example here of smoking cessation in terms of how that field and the research really followed from clinical studies to population-based studies, observational studies, to in which those population-based studies went really informed some more basic research on carcinogenic TARs, and then also leading to additional epidemiologic studies and interventions to really look at smoking cessation. So I think research in general has always been iterative for many, many years. It's something that's part of the reality of the work we do. And so I think it's one of the added values of thinking about implementation science is that we're not just waiting to get the effective interventions into our hands to implement them. I think we can really be change agents and start thinking about designing many of the clinical interventions when they're being tested in the first place. And I'll talk a little bit towards the end about study designs that try to do this. So the NIH definition of implementation has often, I've used this sort of description here just to really think about, from a perspective, if you were at a dinner party and you wanted to describe to folks at the dinner party what you actually do for a living, you can quote the NIH definition of implementation, which is the use of strategies to adopt and integrate evidence-based practices and change practices within specific settings. And, you can use synonyms like in Canada, like knowledge translation or technology transfer. But one of the many questions I often receive is, how is this different from just being a marketing agent or working in advertising? And so, it's something that's important to consider because it's more than just, I think with implementation, it's more than just about, sort of passive dissemination of information to providers. There's more to it. And so the implementation, the way I can characterize it in sort of the, past literature, especially from business, is that it's, not just about publishing or even disseminating your work verbally. I think that it's also important to realize that many things in the world get adopted because of relationships. I think there have been studies showing essentially how people pick their health plans or how people adopt certain habits really are based on the relationships they have with others. And because health systems are continuous and adapting organizations of different types of providers, those relationships between providers is really important to study if you're trying to get effective clinical intervention ultimately into the hands of individuals and helping patients. So it's really implementation science is about understanding and using both top-down, like leadership or mandates or dissemination of important information or academic detailing strategies, but also bottom-up strategies where you equally have to figure out and present things in a way that are going to be of most benefit to the frontline clinicians who are going to be using these clinical treatments in the first place, and obviously from the perspectives of consumers and patients who would be getting these types of treatments. So thinking about designing clinical interventions from all those perspectives is equally important if they're going to be sustained over time. So implementation does involve managing partnerships. It's really, I think that what's very complicated, but also the fun part of conducting implementation science is that you're constantly having to strike a balance between having a good implementation theory and having a great idea for or having an evidence-based treatment or practice that can be implemented, and also, but at the same time, worrying if you're trying to get an implementation study funded, whether the ideas that you have are innovative enough, especially in this funding climate. But also at the same time, there's also enormous opportunities, especially in healthcare systems, to take advantage of time-sensitive opportunities or essentially crises in different healthcare systems where they need to implement new treatments or they need to actually get something out to the field, and how you can actually work with healthcare systems and providers for doing that. And, essentially, as Ross described earlier, your audience is going to be different in terms of healthcare system managers and clinicians versus what we traditionally have been used to in academia in terms of writing journals, that it's important to show a more immediate impact of the work you're doing to implement something, but also be aware that, the idea of conducting implementation science is really about a bidirectional partnership between the environment and the people you're working with to implement evidence-based practice and the investigators who designed or have studied the clinical practice to be implemented. And it really is at most benefit when that relationship is bidirectional as opposed to unidirectional, where you might have situations where you end up having to passively disseminate or implement a clinical practice that may not be ready for prime time because it happens to be a clinical manager's pet project. So I think a broader implementation theory I would like to introduce just to sort of whet the appetite is you'll probably hear about many types of theories and frameworks over the course of the week that you'll be in the Boston area, but the Carl May General Theory of Implementation is a nice one to start with because it essentially outlines the essential components of what I think are really comprised of what we do in implementation. And it's a deliberately initiated process, and this is the definition of implementation, in which agents intend to bring into operation new or modified practices that are institutionally sanctioned and are performed by themselves and other agents. And so the key terms here are processes. So these are the types of implementation strategies people use to get practices into a clinical practice. And so the agents, in many respects, represent the frontline providers. They represent the oftentimes, in most situations, they would be the frontline providers in the healthcare system. And so his general theory really talks about the three main domains, and then really what ends up being the contribution of the implementation process, where you think about the capacity of the healthcare system to implement the clinical practice and the capabilities that are essentially possibilities presented by the intervention that you're trying to implement, and then a potential, meaning the social cognitive resources available to the providers or agents in this situation. And essentially that those three factors really contribute to what actually happens or what happens in the process of implementation. So this paper in particular, it's quite a read. It's rather intense, but I think it brings together many different sociology and psychology theories into implementation. So you sort of get this rich history of where the field has come from. And in general, I think it's important to think about what factors, influence implementation, and really taking from Dr. May's theory or components of his theory about what are some of the factors that might reflect capacity, like organizational resources, the clinic space available to implement clinical practices or new types of clinical practices, the capability of the programs themselves, what components they offer, the potential providers and the recipients, and essentially the day-to-day operations of those healthcare systems. So these are really, I think, you'll learn from other frameworks, how to really hone in on these particular characteristics to really understand what the potential barriers and facilitators might be to implementing clinical treatments into practice. So in terms of applying theory, I'm going to talk briefly about choosing implementation frameworks, but I'd like to sort of also talk about some examples of types of implementation studies that have essentially really have tried to find the best of both worlds of implementing evidence-based practices, but finding the best methods to do so. So theories are, again, as Ross mentioned, really important in that they provide the undergirding or infrastructure, much like the frame of a house, when you're thinking about how to actually get a clinical practice, an effective program into the hands of providers. Some example implementation frameworks that you'll hear about in the coming weeks. These are, again, a couple of examples. There are many, many more, but the ones that have been used often and documented or specified operationally have been a consolidated framework for implementation research, which really is outlined in many respects the wide range of influencers on implementation. Theoretical domains framework, the implementation processes model. Those are more the explanatory frameworks that are used to understand what are the barriers and facilitators to implementation. There are also more directive and applied implementation frameworks that have been geared more towards essentially the process of implementing a clinical treatment into routine practice. So these are more, again, applied towards how do you actually take an evidence-based program or practice and get it into the hands of providers. REAIM is a wonderful example of such a framework, as well as the evidence-based quality improvement. And some of the work from the public health field, the replicating effective programs, is also an example of a type of directive implementation framework, which again is less explanatory, but more about getting the clinical intervention into the hands of of frontline providers. Getting to outcomes is another type of framework that has been used. This is an example of one particular framework that's more directive and applied implementation, and that's the Enhanced Replicating Effective Programs framework. And while it follows a linear pathway, it's really designed to essentially take the steps that are needed to understand what the context is at different organizations, and to essentially basically also understand what is needed to actually implement the treatment into practice, the training and technical assistance, as well as facilitation and coaching. So I'm now finally going to talk about some of types of implementation studies, and I want to introduce this topic sooner rather than later because I think this is where a lot of the innovation in implementation science is going, is the design of implementation studies, and more importantly, using these types of study designs to identify and test tangible and concrete implementation strategies that can be used to promote the use of effective clinical practices in routine care settings. So it's really, these are types of implementation studies where we've seen a lot of studies that have focused on describing the barriers and facilitators, but we're really quickly moving away from more descriptive studies to more interventional studies. And the interventional studies have typically followed what has been described in a paper by Jeff Curran as the hybrid implementation designs. These really are designs that have addressed, again, the limits of stepwise research that we talked about earlier, where you often are in a position where you may not have enough evidence for a clinical treatment or practice, but there's a high priority to get something implemented into the hands of providers. It also is a way of blending the measurement of both clinical effectiveness of the program and the implementation process or the implementation uptake itself. So just to give you some examples of hybrid designs, I mean, well, before we give the examples, I'll sort of outline in a little bit more detail in this particular slide that I think that really are three different types of the implementation hybrid designs. The type 1 design is mainly has been really more around the traditional effectiveness study where the unit of randomization is at the patient and you're really still testing the clinical effectiveness of a treatment or program. And the primary outcomes that are essentially hypothesis tested are the health outcomes. The type 2s are a blend where you're basically still randomizing primarily at this point providers or clinic settings, both a clinical intervention, but parlayed on top of that clinical intervention, an implementation strategy. And an implementation strategy may involve the training and the technical assistance provided to clinicians delivering the clinical intervention, as an example. So essentially, two interventions rolled up into one, and you're testing them. And those are really more focused on, again, when you need to roll out something more quickly because of a high priority goal of a healthcare system. These are the types of blended interventional studies where you're looking at both the patient outcomes and the implementation process as well. They're also the most complicated to do because it's often difficult to tease out the effects of the clinical intervention and the implementation intervention. And then finally, the type 3s are when you're testing different implementation strategies. And in these cases, you're giving all the sites and providers, and essentially these are also studies where you're randomizing at the clinic level or at the site level. All the sites and clinics are getting the same clinical intervention, but the way that that clinical intervention is delivered may differ in terms of using different implementation strategies to get that clinical intervention into the hands of providers and to have the providers use that clinical intervention. So again, the randomization may be by site. The intervention, in quotes, as you may, is actually an implementation strategy rather than the clinical treatment itself. And so the primary outcome here tends to be focused on the uptake of the clinical treatment or practice that's being implemented, and then you're testing a hypothesis around whether or not one implementation strategy works better than another, typically. So this is an example on this slide. This is an example of a hybrid type 3 design where there was a randomization of over 78 service organizations in which they used they actually tested the effects of the Replicating Effective Programs components on the uptake of HIV prevention interventions at 8 service organizations. And this really showcases how, like in a 12-month period, that if you had the full service or the full combination of the REP components of manualization, training, and technical assistance, the uptake at 12 months was greatest for among the 8 service organizations that got the most intensive implementation intervention strategy, which was a combination of the 3 components of REP. So I think just to close, I think that really the take-home points are, it's important to remember that, just as Ross had mentioned earlier, the importance of theory, that it's very practical to start from an implementation theory to really get at the thinking about what are some of the contextual factors out there that need to be influenced in order to improve the uptake of effective clinical programs. The second piece is that the most exciting, and I think also the complicated but most exciting aspect of conducting implementation research is that it's increasingly partnered, because you're often having to work with multiple sites and clinics to get enough of a sample size, but that also affords the opportunity to actually really make a difference at a much larger level to maybe test different implementation strategies in larger clinics and organizations, especially as they're thinking about rolling out clinical interventions. And then finally, I think we're moving beyond just the observational studies of implementation, but towards more interventional studies about learning and understanding what implementation strategies work best. And then finally, I think about, just thinking philosophically about what implementation is all about, it's really fundamentally not only about identifying ways of creating policy that essentially encourage the uptake of effective clinical programs, but it's also working with frontline providers, oftentimes one-on-one, to really figure out the best methods in which those clinical practices get used in routine care in the first place. So I believe I'm done, and I think at this point there's time for questions, or there might be some more information provided to you on the TIDIRH training. So thanks for your time.
Thank you very much, Amy, and thank you, Ross, for your presentations, and also David. We do have the right-hand side of your screen is a section that says Q&A, and if you have any questions, if you could please type them in there. We will try and respond to as many as we can. And I just have one little last bit of logistics. You have been receiving a number of emails from Joanne at the Hill Group, and I want to thank her for all of her support in helping us put on the Training Institute. You have some things that you need to do in preparation for the Institute in July. The first is submission of a structured study abstract. Instructions were sent out and they are due on July 10th. And that abstract is really designed, it's only going to go to faculty that are going to be facilitating small groups. And it will help us determine how to guide the discussions and to make sure that the presentations and the discussions in the small groups are as efficient and answer questions that you have during the session. The second thing that you should be working on and should be exploring are your Ignite presentations. Joanne sent out a link to some sample Ignite presentations and a description of what the Ignite presentations are. On the first day, this is how you're going to introduce yourself and the concept of your research that you're going to be focusing on. When Amy talked about how you would describe your work at a dinner party, this is essentially that type of discussion, and you have 5 minutes. So I would suggest that you review the examples that Joanne provided, and also practice before you come. 5 minutes goes very quickly. Your slides will auto-advance, and it's a fun opportunity, but it also helps you just be very succinct in how you describe your work. Finally, there is an opportunity for all of the trainees to serve as discussion facilitators. I shouldn't say all of the trainees. We only have a limited number of slots. But this afternoon, we're going to have the final agenda posted on the TIDIRH website. And what we really hope that you'll do is you'll review the agenda and see if there are topics that you really want to dig into. And if there's something you want to learn more about, sign up as a discussion facilitator. You will have the opportunity to really focus on all of the readings for that session, review some of the slides ahead of time from the presenters, and you'll get the opportunity to kick off the discussion for that presentation. All trainees will have an opportunity to participate in the discussion, but the discussion facilitator will be leading the discussion. So I did see a couple of questions that have come in. The first is that, will we get copies of these slides? Yes, we will make copies of these slides available. They are going to be posted on the TIDIRH website, but they will also be made available to anyone at the Institute. Our reading list that accompanies the discussion facilitators role will also be posted, and we'll be posting links to all of the articles for the presentations as well before the Institute. So discussion facilitators, you don't have to worry, you'll have enough background. Logging into the TIDIRH website, there is no login. So you can just go to the website, and we'll be sending out a link to everyone to the website and to the agenda. So you should be getting that today or tomorrow. Yes?
We have a question on the chat from Peter Selby. It reads, can you talk about the Interactive Systems Framework by Wandesman and the CDC?
So that?
And I don't know who that's directed to, but I can unmute Ross and Amy.
Okay.
I can talk briefly about it. Yeah, it's a useful framework. It's one of the early, I'm not a systems person per se, but it's Abe Wandesman did a nice job. It's one of the early systems frameworks, and it's one of the frameworks, I believe, in the review we did. It's probably more along the dissemination side of the continuum. It certainly is a system level, so it's a pretty high level, sort of organizational system level of the ecologic framework, but it's one that is, I think, being used quite a lot and is a useful framework, so definitely one worth considering if it fits your research topic.
Sure. Yeah, and this is Amy. I think some of that work also may have led to the Getting to Outcomes implementation framework as well, which is, I think, currently, I believe Matt Chinman has worked on in the VA.
All right, we have a couple of minutes for additional questions. Please feel free to either use the chat or the Q&A. So Silvina Arosi asked about when we would receive the agenda, and the agenda will be posted on the TIDIRH website later today if it's not there already. And the link for that is posted by Joanne in the Q&A, and we'll also make sure it goes out via email. All right. Well, it is now exactly almost 4 o'clock. Please bring any additional questions you have around this presentation to Boston on July 21st. We look forward to seeing you there and look forward to an exciting week of training. So I'm going to go ahead and conclude the webinar, and a copy of the archived version of this will be made available for anyone to review if they weren't able to participate in the full webinar. Thank you, and have a nice afternoon.
Great. Thanks, Cindy.
Thank you, Amy. Thank you, Brock.
All right. Bye.